The final speaker doesn't get the allocated time, but the remaining time, right? Whatever, how many minutes is left is mine, I believe. But we will try to give you your allocated time. Now, when we talk about refractory schizophrenia, two antipsychotics from different groups should be tried for a sufficient time and without sufficient clinical response. That's what we expect. Now, in certain definitions, there is also a time criteria introduced. It says 5 years. In a period of 5 years, no wellness, no well-being. I think that's open to discussion. How effective is it to wait for 5 years? I'm going to talk about treatment in refractory schizophrenia and polypharmacy. Now, all algorithms tell you that two different antipsychotics should be tried for a sufficient period at sufficient dosage. If no response is obtained, then at the third stage, clozapine should be used. If clozapine doesn't benefit the patient either, then it takes you to stage 4, and then clozapine and combinations are used. And then they take you stage 5. Antipsychotic monotherapy is used with agents that were not previously used, and if no response is obtained, stage 6 is actually an area where combining anything and everything goes. So, a patient who does not respond to clozapine, we need to try clozapine combinations on that patient. We have two questions at this stage. Is it switching or combination? Should we switch? Should we combine? Should we do a combination? If you do go for a combination, combine with what medication? Does anyone have an idea? Microphone, please, because we cannot hear the gentleman without a microphone. Okay, we're at stage 4. The patient doesn't respond to clozapine. We need to proceed to the next stage. Do we do combination with clozapine, or do we switch? Stop clozapine and use something else? Well, starting with clozapine is quite burdensome. You need to be very meticulous. You did your checks probably, started clozapine and followed up the patient for a long time. Rather than stopping clozapine and switching to something else, I think going for a combination makes more sense. Anyone has another idea? Now, my opinion is this. There are certain recommendations for depression treatment, bipolar treatment, but for schizophrenia I have not seen any such recommendation. Now, in those recommendations it says if response to a drug is lower than 20%, then it no longer makes sense to do a combination with that drug. Switch it. Isn't that so? Schizophrenia too, I think is a similar case. If a patient has 5-10% response or no response at all to clozapine, I think having a clozapine combination doesn't really make that much sense after that stage. In my opinion, switching is the way to go. If you get partial response, some response that's not well defined though in our clinical practice, even if you have a small response, then you can do a combination with it maybe to increase its effectiveness. But if we have no response, it's time to say goodbye, in my opinion, to that particular drug. So if you're going to do a combination, combine it with what? That's the question. So primum non nocere is the principle, right? Do no harm. So if you're going to do a combination and cause some troubles, then the benefits should outweigh those, because doing a combination also means that you're actually taking certain risks. If our combination doesn't work, what we end up doing is a misuse of medication as a physician. There is no point in coming up with an antipsychotic cocktail if it's not going to do any good. So it has to work. If it has to work, well, there are certain principles we need to be aware of. It's not as if, okay, here goes nothing, right? It should be more well thought about than that, probably. There are certain rules and principles when it comes to combining agents or drugs. Now, the first point we should see, in fact, is what was lacking in the drug we used, or what is our target now, right? Those are the two main questions when you are going to come up with a combination. Özcan Uzun, Professor Uzun, actually has this very nice summary of points to pay attention to in combination therapy. I'll briefly take you through this. Now, the weaknesses of atypical antipsychotics, for instance, clozapine, olanzapine, and quetiapine, they are weak in that they're weak in blocking D2 receptors. If we are to control positive symptoms, if that's our problem, then we need to find something which is good in blocking D2 receptors. We need to strengthen the first medication with a view to D2 receptors. So we need to have something that is more potent in blocking D2 receptors. The classics in terms of that, we have risperidone, amisulpride, aripiprazole in the new generation. That we can choose these to boost the D2 receptor blocking effect in combination. So what else? Now, we have a patient who hasn't even responded to clozapine, right? We are in panic. We're using all of our arms. So, we need to target more receptors to get more of an effect. Now, classical antipsychotics and atypical antipsychotics are the two sides of a coin, as it were. So if you want to target more receptors and positive symptoms, then we need to have a classical antipsychotic and atypical antipsychotic. I think it makes sense. So what else? We may want to boost agonist effect as well. Partial agonist effects on D2 we have aripiprazole, but I think here the intention is 5-HT1A. And clinically speaking, what's the benefit of 5-HT1A? Well, its benefit is increasing dopamine secretion at the prefrontal cortex. There are many antipsychotics in development at phase 3 in recent years, and they have been focusing on 5-HT1A receptor. It's good for negative symptoms, and also it helps a reduction of extrapyramidal side effects in depression and anxiety. 5-HT1A receptor antagonist agonist effects medication. If by combination we aim to control negative symptoms, depressive symptoms, then 5-HT1 effect is what we need to seek. We should have such a drug. Now, drugs should not interact with each other. They should not affect each other's serum levels, blood levels. They should not be metabolized based on the same enzyme system. So olanzapine and clozapine combination is not very logical, or aripiprazole, quetiapine, or ziprasidone combinations are not very logical. But quetiapine and aripiprazole combination is one of the top preferences, unfortunately, but it's not that much recommended from a pharmacokinetic point of view. So, what do we have then? What we have is this. This is a very nice meta-analysis. First-line antipsychotic and another first-line antipsychotic combination was compared to a single antipsychotic, and efficiency difference is not great. It's as if the same. Or second generation antipsychotics combination compared to a single second generation monotherapy of an antipsychotic. Again, statistically speaking, there is not much difference. So you can have both. You can have two new generation antipsychotics, polypharmacy, or monotherapy. There isn't that much difference. So where is the difference? The difference is in combining one antipsychotic from generation 1 and one antipsychotic from the second generation. It is more effective compared to monotherapy of first generation antipsychotics and second generation antipsychotics, so polypharmacy of generation 1 and 2. Now, those of you who are familiar with my affection with clozapine would know that I also prefer combinations with clozapine. And we can clearly see that they are really among the most effective combinations. So clozapine plus one classical antipsychotic, or boosting clozapine's effect in terms of D2 receptor blocking. So a new generation antipsychotic can also be combined with clozapine, and these kinds of combinations have actually now been demonstrated to be superior. So this is what we say in theory, but what's happening on the practical side? We know that in schizophrenia cases, now I think 70% of them refractory, because I'm from the Black Sea region and we happen to think that way. But the general perception is that 25% is refractory, and in refractory cases you really need to have a combination therapy. About 23-25% of the cases you have a combination, in 75% what we have is a monotherapy. The most frequently applied combinations, top 5, the most preferred ones: quetiapine, risperidone, quetiapine, aripiprazole, quetiapine, first generation antipsychotics, aripiprazole, risperidone, and aripiprazole, and olanzapine. So, this actually somewhat overlaps with what we have been discussing in practice. So, the question is, does antipsychotic polypharmacy increase the risk for metabolic syndrome? Because everything comes with a cost, right? If you do a combination, does it come with a cost? Yes. Recently, I had a patient, and I was being told, well, by the relative of the patient, okay, the medication we're going to give will help my patient, the patient will not put on weight, will not be lethargic, and will do the house chores. And I could not tell them to their face that it will be easier to get a divorce from that wife and get a new wife. But those are the expectations of patients and relatives. They want their relatives to get well with no side effects, no weight gain, whatever. Does it ever happen? Or do we get better results with combination therapy? Is there a cost associated? Let's have a look. Now, when you have a combination, it is more effective. We've already covered that. It's been demonstrated. Of course, a combination in line with the principles we discussed. But is there a cost? Yes, there is a cost. Mortality goes up, metabolic syndrome goes up, cognitive functions are further impaired, non-compliance is increased, and the cost of treatment also goes up. So yes, there is a cost attached. So let's have a look at these issues closer from a metabolic variability point of view. Metabolic syndrome is significantly increased when you have polypharmacy. HDL, cholesterol, goes down. We want this cholesterol type, of course, to go up. Triglycerides go up. And waist circumference is also expanded, which can lead to insulin resistance. So that's the case with combination therapy. I've already made the point that combination therapy is actually more effective, but it increases diabetes risk, cardiovascular disease risk, and the more antipsychotics, the higher the risk for metabolic syndrome. Now, our previous speaker, Dr. Reynolds, actually had a similar slide, so I'm going to skip this. Now, what we end up with is this. Now, it's like secondary school maths. So let's have group A, a cluster of group A with antipsychotics of first generation, and have a cluster of B. Now, the common points and the crossing section of cluster 1 and cluster 2, we want this intersection to have the highest number of receptors, H1D2, 5HT1A, 5HT2C. But if we have overlapping receptors, if the two agents affect the same receptors, then the effect on metabolic syndrome and the likelihood of metabolic syndrome would be higher. If they do not overlap that much, then it's better for us. Now, let's see potential confidence: amisulpride, omeprazole, ziprasidone, and haloperidol. So these combinations lead to a lesser degree of body weight gain. Now, one point that we need to underline with these antipsychotics, or one agent, is aripiprazole. Interestingly enough, in leaner people with BMI lower than 23, it has almost the same effect as quetiapine in terms of these individuals gaining weight. In those with a BMI lower than higher than 23, the body weight gain is slightly less. If BMI is higher than 27, then the individuals lose weight when they use this drug. So if you're lean, you put on weight. If you're already fat, you lose weight. So it's good, right? Complete partial agonist effect on weight as well. So leaner people get fatter, fat people get leaner. So this is a difference of this medication compared to others. So what we have in practical terms when it comes to combinations, clozapine and risperidone combinations have shown that there is no difference in terms of effectiveness. The combination doesn't bring you that much benefit, but blood glucose is increased. In another study, effectiveness has been demonstrated, but this time around there is no difference in terms of weight. So there are some contradicting results. Again, when you have olanzapine plus sulpirit, which we think is neutral, no difference in extrapyramidal side effects or weight. So it's as if you're not using it. Again, ziprasidone plus clozapine combination show improvement in symptoms with weight loss. So these two antipsychotics, when combined, they don't have a high number of overlapping neurotransmitters which they affect, which are connected to weight gain or weight loss. In another study, risperidone was compared with clozapine with risperidone. When aripiprazole was combined with clozapine in another study, significant decreases in weight occurred and triglyceride cholesterol was also reduced. Now, one important point I would like to underline is this. Sometimes statistics might be misleading. When a patient puts on weight, you can reduce the patient's body weight by adding another antipsychotic. And certain meta-analyses have shown, for instance, patients with 100 kilogram weight gain or reaches 100 kilograms rather in body weight, when a neutral antipsychotic is added, there is a weight reduction of 10%. But clinically speaking, 100 kilograms or 110 kilograms, there is no significant difference, because in both cases BMI is high. So in these kinds of studies, the treatments that are added might sometimes have misleading results. And I think the average from one meta-analysis in terms of body weight lost was 5.7 kilograms. Now, Professor Alpay asked a question about, well, let's start with olanzapine, and so the patient puts on weight and then switch to something else so that they lose that weight. Well, that's not always the case. Now, the principle is, of course, not to gain weight, not to put on weight in the first place. Now, when you have the word control in it, it's dangerous. Body weight control, anger control, or anger management. I mean, sometimes there is no limit to one's anger. The same might be applicable to weight loss, weight gain. The same applies to substance abuse. So it's very tough to control one's body weight later down the line. This is also a very nice study, but the problem is that it only lasted 6 months. We usually switch from monotherapy to polypharmacy. Now the trend is reverse. And 6 months later, they said that there was no difference in terms of the severity of psychotic symptoms. And there's a slight decrease in BMI of participants when they switch from polypharmacy to monotherapy, but the symptoms do not change that much. But the change in body weight is also not that significant. Well, we should not start thinking that nothing happens when you switch from polypharmacy to monotherapy. This is simply a 6-month study, so certain things might be happening in the long term. Now, if you already have a balance going with the patient, I don't think that you need to fiddle with that balance that much. Thank you. This was the end of my presentation. If there are any questions or contributions, I'll be happy to answer the questions.
Thank you very much, Dr. Özcan.